I'm Sister Callista Roy, professor and nurse theorist at the Connell School of Nursing at Boston College. I'm introducing to you the book, Generating Middle Range Theory, From Evidence to Practice. In this project, we were proposing a unique approach to relating theory to practice by way of research. By uniting the strengths of theory and of research as the basis for practice, and we want to accumulate studies based on similar concepts, the concepts of a grand theory, and then capitalize on the benefits of middle range theory. So in part 3, it deals with the actual generation of the middle range theories. And it covers 5 chapters that will explain each of the middle range theories. So we'll be looking at middle range theory of coping, as well as the synthesis of middle range theory of adapting to life events, adapting to loss, to chronic health conditions, and the adapting family. The team had early on worked on a 6-step process for developing and generating these middle range theories, and this will be used in each of these chapters in part 3. And as we use it each time, the process will become more clear. But basically, we will start out by selecting the studies that cluster by way of similarities. Then the studies themselves are used as the observations to classify the major concepts. The concepts we want to be distinct and observable, but at the level of abstraction that can be generalized across clinical situations. We'll be looking at major categories such as stimuli, the coping processes, and the adaptive mode outcomes. Step 4 of the process relates to the fact that the concepts are used to draw a pictorial schema of the interrelated concepts. The next step follows on that, where the interrelated concepts are stated in a theoretical statement, also called a proposition. And then the last step is the one we find very important, because that's where we want the findings from the research to be used to provide evidence that can support the new middle range theory and also recommend changes for practice. So in chapter 7 then, there's a synthesis of the middle range theory of coping. And as I noted, it follows the series of steps we just talked about. But in step 1 is the selection of studies. There were 13 studies selected here. And the samples included adults with chronic pain, community-based elders, individuals and couples, informal caregivers of a relative with dementia, of a psychiatrically ill relative admitted to a psychiatric hospital and during remission, as well as professional caregivers in geriatric long-term. The methods in all of these studies were basically quantitative. They were those that explain, predict, and use structural equation modeling, experimental, pre-test, post-test with a control group, mixed methods, and a priori theoretical modeling with structural equation analysis. Now, in putting together the schema, we actually can show then the steps that we've been talking about, the concepts being the first step, and then those concepts needing to be at the middle range, that being the third step, And then the fourth step, getting to our pictorial view. So by looking at this view, we can actually show those steps. So here is where the steps of the process will become clear. So look at the schema, column 1, and you see the different types of stimuli according to the model. So those of you familiar with the model will recognize that we are able to identify within these studies what is the focal stimuli, the one being focused on either by the patient or group that's being studied, the contextual stimuli, all other factors. So in these cases, what we had was aging and chronic pain, perceived stress of caregiving, terminal illness and death of a loved one. Contextual factors included race, gender, caregiver burden, availability or enacted social support, and conflicts in social support, as well as hospice support. So then, those stimuli were being dealt with by the coping strategies internal to the person or group. And there we had such factors as active, non-religious coping, religious coping, passive avoidance coping, cognitive and emotional ways of perceiving, and creativity. Go to the final column, 3, and you see there the outcomes. And these then are described in relation to the adaptive modes as the investigators studied them, and then the author clusters them. So we have adaptive self-concept responses, decreased psychological distress, spiritual well-being, adaptive role responses, and the ability and satisfaction in caring for the other. Now, the fifth step of this whole process then draws upon the schema to pull together the concepts and put them in theoretical statements, also known as propositions. In this particular chapter on coping, there are 12 propositions. So as you look at these, let me highlight a couple of them. First, active coping strategies lead to changes in the stimulus of perceived stress and to adaptation manifested by less psychological stress. Go down to number 3, cognitive coping of important decision making is helped by support of health providers. And number 4, religious coping used by those in chronic pain leads to positive self-concept, less depression, and psychological distress. Spirituality is a strategy used to cope with bereavement and to adapt effectively. So you see in all of these, the ones I highlighted and the others as well, that we're moving from something to cope with, the process is coping with it, and the outcomes. So the statement is primarily between two terms, but all three are implied. In the next set of propositions then, 6 through 9, the two I want to highlight are the last two. Support, such as hospice, leads to adaptation to care for the dying. Although fewer coping strategies were used in these situations, they are more effective, and similarly, available enacted social support for caregivers has a direct effect on active coping. However, according to Proposition 9, conflicts in social support among caregivers relates to passive avoidance coping strategies and to greater psychological distress. The last three propositions then, let me focus on the two that both have demographics. Oh, they all have demographics, but in particular, The demographic backgrounds do not have as much influence on some of the outcomes as reported. For example, the level of self-reported pain intensity in elders was not related to age, gender, culture, or race. And then looking at number 12, race has some effect on creativity. As in a sample from Senior Center, Black participants scored higher on creativity pre-intervention and post-intervention in both control and experimental groups. When the effort was to improve successful aging by increasing creativity. In other words, this group were highly creative. And as they talked about it, the reviewers felt that it had to do with, they talked about the things they had faced in life and what it had brought them. Now, what is important to us is that what we learn can bridge the gap between theory-based research and practice. So each chapter then, and chapter 7 that we have before us now, ends with a practice recommendation from the middle range theory. So this being the middle range theory of coping. The development and widespread use of patient teaching tools on coping was what we were really going to advocate for. And it's possible that we can have electronic format applications that are created that lead persons to recognize their preferred coping traits with embedded videos for the person to identify the causes most like themselves. They can also receive prompts that provide understanding of these approaches and how to use them effectively. They can learn about using new strategies in times of change and ways to be prompted to contact their nurse coach to make changes in coping and to receive the support they need at a given time. So turning now to chapter 8, a synthesis of the middle range theory of coping with life events. Again, in step 1, we select the studies, and in this case, 12 were selected. The samples included perioperative nurses dealing with physician verbal abuse, emergency nurses handling traumatic and violent events, nurses involved in abortions, older adults, college students, and adults handling dating or intimate partner violence, women with menopause and postpartum experiences, mothers of infants in the neonatal intensive care unit with severe cerebral palsy, with cancer, and preschoolers who were having injections. In all these studies, the methods used included survey descriptive correlational, phenomenological, predictive correlational with regression analysis, survey using causal modeling and path analysis, and a 2-group intervention. The schema for the middle range theory of coping with life events, the developmental events, shows us then the steps of creating the middle range theory, steps 2, 3, and 4. In step 2, again, we will look at the major concepts, and these are classified according to the stimuli, the coping strategies, and the outcomes. We will try to put these at the middle range level, and then, which is step 3, and step 4 is connecting them together in this schematic drawing you see. The developmental events were divided into 2 broad categories of stimuli, and then the specifics under each one you'll read in the book. The internal challenges included such things as menopause, motherhood, etc. And then the external challenge was the one study that was children who were receiving immunizations. The coping strategies then had to do with involving personal and physical self with a positive attitude, initiate direct action, expand input, expand strategies, selective attention, fixed focus, or change focus, plan ahead, use resources and experiences, and systematic handling. And lastly, relate to others, and this came in different categories: for help, for support, and for emotional sharing. In the coping strategies for the external challenge, in this case, the nurse was changing the child's focus. The last column then shows the adaptive outcomes, and these were summarized as effective role transition, higher self-esteem, interpreted sensation, and positive health attitudes. Then on the level of life events that are situational, there were many of these, but in general, as far as stimuli, we call them specific event challenges. The coping strategies here were problem-focused behaviors, the use of knowledge and skill, the use of self, spiritual well-being, and moral ends, humor and time perspective, and relating to others for support and empathy. The health challenges, the second type of situational events, involved coping strategies of having a common language, unique bonding and connecting, focus on the good, the duty to be strong, and counting on others. The outcomes then, in the first category of specific event situations, involved role effectiveness, teamwork, moral distress, resolved or unresolved, and protected mental health. In the health challenges, the outcomes included personalized attention, lessened anxiety and fear, and craving normalcy. So in this middle range theory, we have again the propositions for coping with life events, and there are 12 of these. So let me highlight a couple of these. The Cognator processes of taking direct action, planning ahead, handling systematically, and use of resources and experience can affect adaptive responses in self-esteem, role transition, sensation, and health attitudes. The second proposition notes that in new role development or unexpected role events, expanding input can lead to effective role transition or role effectiveness. So you see the other propositions then also relate the concepts from the first column, the processes in the middle column, with the outcomes in the last column. So you can read through a few of these and see that, again, the processes in particular are affecting the outcomes. And two of them I want to highlight towards the end here are number 10 and 11. The use of a common language between those dealing with health challenges and the nurse can lessen anxiety and fear. The pooled effect of contextual stimuli such as context, age, and socioeconomic status, and residual stimuli such as childhood abuse and witness of violence affect the mental health outcomes of abuse. So again, lastly, in this chapter, we really want to be able to make practice recommendations from the middle range theory of adapting to life events with the support of the research. So we propose major responsibility for every nurse in practice to coach each patient in the use of the person's own effective coping strategies to promote adaptation. That is, which strategy to use under which circumstances, and what situations can call for new strategies. Nurses in outpatient, home care, and acute care settings will be aware of the need for coping with developmental challenges, whether in pediatrics or in care of the elderly. Similarly, when patients across the lifespan are dealing with health challenges, they can also be dealing with situational life events. We turn now to Chapter 8, the synthesis of middle range theory of loss. And in selecting the studies for this middle range theory, there were 8 studies that were relevant in particular. And we show here on the slides both the subjects and the methods. Most of them were qualitative studies. 3 studies related to the death of a spouse. 3 studies explored the experience of persons who are experiencing their own death. As I said, they were mainly qualitative. Phenomenological studies included 2 interviews of 5 women who suffered the untimely death and the loss of a stillborn infant. There was 1 quantitative study which was descriptive correlational of 65 grieving widows in the 2nd year after death of a spouse, and it explored the contextual stimuli of social support, social network, spiritual beliefs, and demographics, which were linked to an adaptive outcome of coping processes and grief responses. So then, the middle range theory of adapting to loss, as we look at steps 2, 3, and 4, again we identify the concepts, and then we try to put them at the middle range level and relate them in the schema. So here we have the major focal concept of loss as a profound emotional experience, the contextual social support and spirituality, and residual time of enduring. Residual because it's not exactly established but has to always been taken into account. The coping strategies then at the regulator subsystem and the cognator subsystem deal with self-reintegrating to loss by processes of resolving, resigning to loss, overcoming loneliness. And another major process of oscillating complex processing from grieving to resolving. Then in the 3rd column there, the outcomes represented include in the physiologic and physical declining health, primarily of the caregivers. Self-concept area, finding and constructing meaning, going forward, being strong, finding strength, forcing self to go on, and in role, relinquishing previous roles, assuming previous roles, interdependence, creating memories, remaining connected, connecting to others and a higher power, and forming new relationships. We can now go over the 6 propositions derived from the middle range theory schema. Here we have the propositions for middle range theory of adapting to loss, and there are 6 of them. Adapting to loss is a profound experience, and the focal stimulus impacts both coping processes, that is, the cognator and the regulator. Adapting to loss is purposeful, and the responses of bereaved individuals cross all 4 adaptive modes. Adapting to loss is influenced by the contextual stimuli of social support and spirituality. Adapting to loss involves connecting to others and a higher power, going on and moving forward, and finding meaning in loss. Adapting to loss takes place in stages, in a back and forth motion, oscillating movement from grieving to resolving. Reintegrating oneself involves relinquishing old roles, learning new roles, and forming new relationships. The recommendations then from the middle range theory of loss, as supported with the research. In practice, we need to have a consistent awareness and sensitive response in all areas of nursing practice to needs of those suffering a loss, and include both males and females, because the researchers found a difference. The males found they were getting more direct help from people, that is bringing casseroles, but they weren't getting the emotional support that they wanted. Policy-wise, we want to look at the nursing diagnosis of grief in any form of dealing with loss to be a reimbursement code that does not place a limit on the length of given for a visit or for the time frame for visits for those suffering loss. In Chapter 10, we follow the same pattern, beginning with the authors selecting 20 studies to use in synthesizing the middle range theory of adapting to chronic conditions. The samples include adults with heart failure, diabetes, multiple sclerosis, HIV/AIDS, and kidney disease, adults with end-stage renal disease, women with breast cancer, children with HIV, young teens with asthma, adolescents diagnosed with ADHD or with cancer, women in rural areas with chronic health conditions. The methods used in these 20 studies included qualitative naturalistic design, quantitative descriptive correlational, survey studies using multivariate analysis, exploratory regression analysis, predictive structural equation modeling, and an intervention study of group comparisons, and an intervention study with a single group, pre-test, post-test. Moving then to the schema for this middle range theory of adapting to chronic health conditions. Steps 2, where we identify the major concepts, we list them again according to the stimuli: focal, physical change and symptoms, treatment effects, and perceived threat and challenge. The contextual, the rest of the stimuli present, the meaning of illness, social support, and personal resources. Residual developmental stage, the time and setting. These then are handled by all the coping strategies. And in this set of studies, what we found were the ones that are at the individual adaptive processes. The Cognator included learning, information processing, problem solving. The regulator had physiologic controls, self-management, reappraisal, and spirituality. Engaging with others were extrinsic, health care seeking, nursing interventions and treatment, and seeking social support. The last column then includes the outcomes. The coping strategies then lead to the outcomes: improved functional ability, stabilization, decreased symptom severity, normalcy in terms of transformation, self-management, high adjustment, and spiritual well-being. In the role function mode, role consistency included empowerment, utilization of information, and utilization of support. The propositions for the middle range theory of adapting to chronic health conditions were divided as the clusters of propositions relating to the Roy adaptation model. So we're going to cover just two examples of these. And the first relates to the proposition of coping of the individual. So on this slide, we see the first one having to do with perceptions change over time and reflect reappraisal, adaptation resulting in normalcy or a new normalcy. Remember, we're dealing with coping with chronic conditions. The adaptive processes then in these situations include empowerment, embracing changes, seeking social support, problem solving, self-efficacy, and taking responsibility for self-management. The Cognator processes include information processing and learning about the chronic condition, and may include personal spirituality in support of these cognitive emotional processes. Fourthly, the regulator mechanisms are adaptive when treatments and lifestyle modifications are effective. Self-management as adaptive processing requires both knowledge and application of that knowledge, integrated with responsibility to transform the individual. So this whole set of propositions relates to the internal coping of the person. Now, another set by these authors is the one that talks about propositions relating to the chronic conditions which involve the nursing process. First, nursing intervention may function as a primary adaptive process with improved functional ability, that is stabilization, symptom control, as a major goal or outcome. Nursing interventions of education and social support are integral to adaptation over several modes, building knowledge, self-esteem, and empowerment. And thirdly, empowerment is evidence of role consistency and self-integration in adaptation to chronic conditions. In chronic conditions in practice, we are eager, in particular, to relate our research-supported middle-range theories to practice. So our authors have provided this recommendation. A recommendation for practice is that all nurses use Q questions to elicit in-depth responses in any setting, working with a person in a situation of transition of a chronic condition. Questions such as, how do you feel you're handling the change? Or how have you changed? Or how do you see your future? The aim is to engage the persons in ways that show caring and can build rapport and trust. When the nurse-patient relationship lasts over time, there is great potential for promoting adaptation throughout the lifelong process of chronic conditions. The policy recommendation from this middle range theory of adapting to chronic conditions that has the support of the research. First, the role of the nurse in community-based primary health-related settings will be expanded to the full extent of their education and training. 3 settings where nurses can take major responsibility for promoting adaptation to chronic conditions are schools, camps, and community-based programs such as support groups and nurse-managed clinics. So the authors discuss examples in each of these areas. The last chapter of Part 3 is Synthesis of Middle Range Theory of the Adapting Family. The authors selected 13 studies to synthesize this middle range theory. The samples included Mexican-American first-time mothers and fathers from the 3rd trimester to the child at age 4, family caregivers, family with fertility problems, parents facing choices related to fetal anomalies, and family members deciding about genetic testing. In this set of studies, the methods included qualitative exploratory descriptive, qualitative grounded theory, ethnography, quantitative exploratory descriptive correlational, and quantitative predictive multivariate analysis. The middle range theory schema then identified the concepts, again, within the categories of the stimuli, the coping processes, and the outcomes. So in the first column there, we have the family stage being a focal part of the situation. The life events include threat of loss, well-being, or health, caregiver status, and burden of caregiving. Contextual stimuli are social concerns, perceptions, knowledge, physical status, and relationship. The coping processes involve the stabilizer, nurturing and support, socialization, support, instrumental, physical caregiving, and expressive, physical emotional needs met, and cognator processes of decision-making, adjusting behaviors, attitudes, and expectations, constructing a cause and communication, and distancing, avoiding awareness, and placing blame. In the last column, then, we take all of these and look at the outcomes in dealing with the stimuli of the first column, processing it through the processes identified in the second. The outcomes then are healthy family, that is growth, survival, and coherence, accountability in role performance, perceived quality of life, self-esteem, and self-reliance. Or with the distancing, we get social conflicts, depression, regret, and loss of sense of control over life. The propositions relating the concepts of the schema totaled 13 for this set. The first one being an overall relational statement. The family is an adaptive, dynamic, relational entity. Secondly, the adequacy of cognator regulator or stabilizer innovator processes will affect adaptive processes, leading to family growth, survival, and coherence. Transitions, although inevitable, are particularly stressful times for families. The nature and perception of the changes, that is, the focal stimuli, influence adaptation within the family. Family nurturing, support, and socialization are relationally based. Family coherence is demonstrated through love, respect, and loyalty, and providing understanding and companionship. Family growth, survival, and coherence, that is, adaptation, are related to social support, communication, sharing, planning, and utility. To achieve harmonious relations within the family, behaviors, attitudes, and expectations must be adjusted. That was particularly in studies of relating caregivers and care receivers. Adaptive processes in all modes are interrelated and overlap, working together. One mode can compensate for ineffective coping in another mode within the family. Age, physical health, social support, and purpose in life are predictors of quality of life and functioning of the family. A disruption of relationship can lead to depression and interfere with adaptation in any individual's adaptive modes. Nursing interventions respect family values, and address expressed concerns of the family. Nursing interventions link families with community. In closing part 3, we look briefly at the recommendations from the middle range theory of the adapting family with the research support. In practice, we want to provide interventions that will link families with the community in a meaningful way, introduce the family unit to key individuals, identifying the help available along with the expectations and means of participating. On a policy level, what this means is perhaps to have nurses help to implement a change to introduce a meaningful family history that is effectively used by providers to plan care for the adapting family.